Missed you at the Mediterranean Summit.
Yeah, it wasn't possible to me. I was dealing with some health issues.
Health issues. Yeah. Jonas told me. Sorry to hear about that.
But I'm okay. Okay.
Oh, that's good.
Thanks, God.
How are you, Neil?
I'm good, Jonas. How about you?
I'm fine too. Working so much to make everything work properly. Today is a good day in Fortaleza. I hope we don't have any problem with the internet connection. Yesterday, where we have some problems here, but I think today it's okay. And Melbourne, how was Melbourne? You are working to organize the course?
Yes. Still working, so I'm yeah. So I will let you know.
Okay, fantastic.
Keep me posted of any other developments.
Dear colleagues, Dr. Neil was the first student at the Institute of Sormani Queiroz. We have a very, very love for Neil. He's a great guy. And
Thank you.
Neil was with us for 2 times. He loved the course. Thank you so much, Neil.
Oh, no problem. Dr. Sormani was amazing.
Okay, Christian is here.
Thank you, my friend.
Hashi, Mr. Khalif, welcome to this webinar. Well, to begin, I would like to say some words for you. I prepare a few words now, and I will read this test for you because I think it's very important. This webinar was created with a very clear purpose: to build an active clinical community, bringing together professionals who want to grow together, share real experience, and continually improve their daily clinical practice. Our proposal is simple and consistent. Starting with this initial session, we will hold monthly free webinars focused on discussing real clinical cases presented by the students themselves. We will analyze treatments approaches, alternative solution planning strategies, and clinical decisions making. This is not about isolated theoretical lectures, but about creating an ongoing space for learning and professional exchange. This environment will also help facilitate enrollment in Dr. Sormani clinical course, scheduled for June 2026, allowing interested participants to become familiar with the course structure, philosophy, and expected well in advance. This course will be in Brisbane in June. During this session, we will also present in more detail our clinical training programs with real patients in Fortaleza, an intensive hands-on model designed for professionals who want to gain true clinical experience through high case volume and close supervision. This is an open and collaborative space. All participants are encouraged to invite colleagues and peers to join the webinars. Participation is completely free, and the larger the community, the richer the clinical discussion becomes. If you value hands-on experience, honest case discussion, and consistent professional growth, this community is for you. Welcome. Well, I give the word to Dr. Sormani. Thank you so much, Dr. Sormani. The webinar is yours.
Okay, thank you, Jonas. To me, it's a great pleasure to welcome everyone here. My friends, I see that Christian is here, Mohit is here, Rashi is here, and Neil and the others. So to me, it's really a pleasure to meet you on this webinar, and I hope we can meet together very soon live talk some words each other, and of course have a great time in Australia or here in Fortaleza. So we had this idea with Jonas of creating this community, because sometimes we can't stay in touch with everyone on the internet, Instagram or WhatsApp, whatever. And I think we can here share more, knowledge after the course that we have live here in Fortaleza. So I'm very curious to know how you guys are doing in your clinical practice after the course. Some of the participants will be the doctors that will come in the future to Fortaleza that didn't came yet, but most of you are the doctors that already did my course here. So I'm really, I'm really curious to know how are you in your practice, what are you doing. So this webinar is not about me, it's more about us, about you guys. So it would be great if you in the future could show your cases here, how I'm starting to show some of the cases now. So in fact, some of these cases that we will discuss here are cases that we did in the course. So some of you will have an update of the case that you operate or that you followed during the course. And so I hope that this can be a really rich discussion of cases, and you will learn a little bit more about how to conduct these situations. And to start these webinars, I selected a case of complication, okay? A case that was really tough to conduct, because in the course of this case, we have some troubles. We're dealing with troubles. I will show you how we deal with these troubles. And I think it's important to you to know that not everything is straightforward towards the successful management of the cases. Sometimes we have troubles, and this it doesn't matter if you are a beginner surgeon or you are an experienced surgeon. You will have these situations, and you have to be prepared to deal with these situations. To be honest, today I think my practice, my clinical practice, my cases are in my private practice. Half of the cases that I treat is, treating complications of other doctors that refer to me. So this is in part because of the doctors trying to do things like complex cases that they are not trained to do, and some of these cases are just because complications happen. So, and sometimes we don't have the experience. You don't have the experience to deal with these complications, and as I am, in this field for much more time, sometimes the doctors refer these cases to me because of my experience. So on the other hand, you just will have experience treating complications if you have complications. Fortunately, the complications with these techniques are, are the exception is not routine, but if you do these cases, you will have complications. Okay, so I hope that you enjoy. I will show you now how I treated this case, and we will discuss a little bit more about it. So I will share my screen here. I hope that you are, seeing this my screen.
It's okay.
It's okay. So let's go. So this is the case that I selected to start these clinical cases discussion sessions that will start today, and I hope that monthly, at least, we will have this discussion on different clinical situations. So this case is from a female patient, 59 years, with no systemic disease, non-smoker, and that is taking no medications of any type. And we are seeing here, I started to treat this patient in 2017. We see here the patient, this lady, and this picture is just to see. It was shortly after the procedure where we placed two zygomatic implants and two conventional implants, and she had this facial paralysis. And when you have this situation, almost all the cases are due to the infiltration of anesthetics that we do extraorally in the area of zygomatic bone here. So sometimes this anesthetic spreads to the tissues and can lead to paralysis of the facial nerve, the frontal branch of the facial nerve that will innervate this area here, and the patient is unable to close the eye. So this we will return to normal function of the eye after a few hours, when the anesthetic effect will pass. So this is not a problem. It's just a curiosity that I like to show to everyone. So this was the situation that I had with this patient. She was referred to me with these 3 implants, but of course this is not enough. To stabilize this prosthesis. So we were afraid that this could lead to the loss of this work, and we choose to install two zygomatic implants because I don't have the initial CT here anymore, but this lady didn't have any bone in the posterior zone. In fact, she had 2 posterior implants here. She had two standard implants here, but she lost this posterior implant, so it wasn't possible to place another standard implant, and we opted to place 2 zygomatic implants to complete the anchorage for full arch case. So in 2017, we placed these 2 zygomatic implants in the posterior area. At that time, we used to use this kind of implants. It was a external X implant with threads all the way on the body of the implant, and with the rough surface as we see here. At the time, we achieved a good primary stabilization, and we immediately loaded these implants, incorporating it to the provisional prosthesis that the patient already had, and we think that that was a good solution to this clinical situation, and we were very satisfied with the final result at the time. So it was in 2017. This was the static aspect. The patient was happy, and we were happy with the final result here. But 6 years later, this lady came back to me, and she wasn't very compliant with the follow-up schedule to maintenance of the work. But she, in 2022, she came back with this situation. We removed the prosthesis. We had some problems with recession of soft tissue here. We can see that, in fact, these implants, this left mainly, it was, it wasn't in a good prosthetic position in terms of vertical positioning. You can see that the platform it was too much out of the soft tissues. But the problem wasn't with the soft tissue. The complaint of the patient, it was that she was feeling that everything liquid that she was drinking, it was gone through the nose, so entered in the mouth, and it was going out through the nose, and she felt like the air was passing from the mouth through the nose. So with this, we could, diagnose a oral antral fistula through this area of the zygomatic implants. So we inserted a periodontal probe through the sulcus, and we could see that really we had this communication, this oral antral fistula here on the left implant and also on the right implant. And this diagram tries to elucidate how this situation works. So we have the implant here, we have the palatal mucosa here, the buccal mucosa here, and we have the implant going through the sinus from the crest. And when we enter the maxillary sinus directly from the crest, if we don't take some care to protect the membrane, and sometimes placing a collagen membrane to isolate the maxillary sinus, we can have this continuity between the oral epithelium and the sinus epithelium here. And of course, this is a oral antral fistula. It's a potential oral antral fistula. And if something, make the rupture of this epithelial adhesion here, and this epithelial adhesion is very thin, it's easy to rupture. So if something disturb this area, like for example bacteria, biofilm, or even a mechanical trauma or any kind of inflammation, you can have a direct communication between the oral cavity and the maxillary. So if this happens, you will have all the liquids and food and oral bacteria that can invade the sinus and will maintain a sinus. So this is how this kind of problem will be installed. So in this case, we will have to take some action to solve this problem. And with this kind of implant that we saw here, with this kind of implant that we placed here, it's if the biofilm, if the bacteria or calculus or something reach this area here with the threads and the half surface of the implant, it will be impossible to clean it, to remove this biofilm, even if you do something to smooth this surface. It will be very difficult to decontaminate this area. And most of cases with this kind of implant, we will have to remove the implants. So it was what we did in this case. So this is, I'm sorry about this documentation of the images. This is a very old case, so I don't have the original files now, but we can see this is a 3D reconstruction, a panoramic reconstruction of the CT scan. So you can see here both the implants here, and the image is not good, but we had signs of liquid inside the sinus bilaterally, which indicates that we had a sinusitis, a bacterial sinusitis caused by the implants. And we had these 3 implants, and we can see here that these implants were inside the nasal cavity, and this in the future it was another complication that we had with this patient, and we'll see in the end of the case. But at this time we were focusing on solve this problem with the sinusitis. So we can see here the 3D reconstruct of the same case. And in 2003, we tried to solve this sinusitis only with medications and local care, but it wasn't possible to stop the signs. So the patient had constant fluid draining from the nose and from the sulcus of the implants, and she had another signs of symptoms of sinusitis, like, so she had swelling of the base, she had pain, and she had that bad odor coming from the nose. So this is very characteristic of the sinusitis. And we opted to approach the area, and we ended up removing the implants. Although the implants were stable, but it was not difficult to remove. Maybe the osseointegration of the implant was not that good at that time, so it was not difficult to remove the implants. We used the mounter of the implants, and it was relatively easy to broke the osseointegration. And we can see here that we had anterior attempts to smooth the threads of the implants that didn't work, and we have lots of calculus and plaque and biofilm all the way in the body of the implant. So this shows us that it was impossible to clean this implant, and that this implant was maintaining the sinusitis of the patient. So when we see in the mouth after removing the implant without raising the flap, we think that the size of communication here was small, but we did the same thing on the other side, and same situation here, calculus and plaque and biofilm and contamination all around the body of the implant. So again, this is impossible to remove. So this was maintaining the sinus, and it was impossible to clean this implant. So the only solution for here to solve this situation is removing the implant. There's no other way to treat this than removing the implant. If this implant it was like the implants that they use today with a smooth polished surface all the way until the apex with rough surface only in the part of the implant that will be inside the zygomatic. So if this was the case of this implant, we could maintain this implant cleaning the surface because it's easy with polished surface. We don't have this plaque that adhere the surface. It's easy to remove. So we could think in maintain an implant if the implant was different. The macro geometry of the implant it was different, but it wasn't the case. So you had to remove the implant. So you can see here, and we see that all the surface of the implant was contaminated. And again, we see this and we think this is just a small communication. It's not that big. But when we raise the flap, we can see that the communication is really, really big. It's larger than we can see in the mouth. So that's why this is like, sometimes it's a bait. Sometimes the patient, the doctor thinks, no, I just have to approximate the edges here. It will be easy to close, but we see that this kind of communications, if you don't mobilize larger flaps here, if you just do a simple suture here, it's almost sure. I'm sure that we will have a relapse of this wound, and the communication will continue in the future. So we have to really to mobilize a larger flap here, expose all the defect to see how large it is. So based that in that size of the communication, we opted to take a flap, a pedicle flap from the buccal fat pad. To me, this is the best way to manage these communications at first. So we mobilized the buccal fat pad and closed it, suturing in the edges of the defect. Okay, we place some sutures here in the edges, so we have to be sure that all the defect will be covered by the buccal fat pad. And we did over this flap, we placed a pedicular palatal flap over it to close in 2 layers. So this is the ideal way to do it, in my point of view. And on the other side, same thing, big size defect, exposed buccal fat pad, mobilize it, covering all the defect with DFP. And after that, in this side, on the left side, I did it, use it the palatal flap. I didn't rotate it, the palatal flap. I just released the buccal flap and sutured over the buccal fat pad. So we had 2 different ways of achieving a double layer closure of the defect. So this is a good way to treat these really large complications. Today, I like to to put another layer with a collagen membrane. So the first layer is the collagen membrane fixed to the edge of the wound of the defect with tacks of screws or whatever you want. So I stabilized the first layer with the collagen membrane, and then I cover it with the BFP, and then I cover the BFP with the uh, mucosal or palatal graft, so a flap. So we have a three-layer closure of the fistula. And here are the implants that we removed. So you can see how we have really a great amount of contamination of this implant. The threads are covered with plaque and contaminants, so it was impossible to remove this contamination from this kind of implant with threads and the rough surface. So we attempted to smooth the threads here, but it doesn't work. And after we see that this was loss of time, this wouldn't solve this situation at all in any circumstances. So here is, I think, like let me see, here is almost 1 month after the surgery. We can see here we have the sutures is still here. The patient lives in another city, so it's not easy to her to come back. But she came back almost 1 month later to remove. But I was I was in touch with her, and I was following, and she said immediately that stop it to pass liquid from the mouth to the nose, and all the symptoms that she had were improved, were better, and we were pretty satisfied with this situation almost 1 month after the surgery. So this was when after we removed the sutures, and we left the prosthesis only in these 3 implants. So in the end, so we were back to the initial situation in which she has only 3 implants with that prosthesis. So placed the prosthesis back only over these 3 implants, while we were thinking about a solution for her case, because she was not, she didn't want to try another zygomatic implant, and I was not, I didn't want to do that kind of treatment again, because she had really a bad time with the symptoms and etc. So I was figuring out what would we do to solve the situation. So meanwhile, we let the prosthesis in place, only fixed in training implants. And we were following patients, so we placed the prosthesis over the 3 implants left. And this is 1 year after the first surgery, after this surgery, closing the fistula, and the things were really good. The patient wasn't with any complaint about the maxillary sinus, and the prosthesis were still over these 3 implants, and everything was okay. So I was not rushing to solve this problem. I was, gaining some time to do something later, trying to figure out how to solve this situation, because she has no bone to place implants here. and the prosthesis still okay. She has no complaints about the situation. But in December of 2024, she came back, and now the problem it was with this implant here. So she was complaining of inflammation through the nose, and you remember that I showed you that two of these implants were inside the nose, and this implant was causing an inflammation inside the nose of the patient. She went to ENT doctor, and he did a endoscopic uh, examination of the nose with a camera, and in this nasal endoscopy, he saw that the the apex of the implant was exposed through the nose, perforated the membrane of the floor of the nose, and there was inflammation and infection around the tip of the implant inside the nose. And the patient was again complaining of, pain and drainage of pus and a bad odor and everything related to this inflammation, this rhinitis. And we had to make something. The problem was, uh, this is the CT scan of this patient that time. This was the ENT surgeon that asked for this exam. The good news were that the sinus, both sinus, were really beautiful, clean, without signs of infection, without signs of membrane uh, inflammation. So the treatment that we did, removing the implants and closing the oral antral communications, were good. And we can see that even at the level of the crest, we had no problems with the maxillary sinus. So we could manage well the problem of maxillary sinus. And we can see here in the coronal uh, slices that the oral-antral communication, although the bone didn't form, of course, at the level of the defect, but it's very well closed with the soft tissues, and the maxillary sinus are really good, healthy, and no issues regarding the maxillary sinus. But we had this is the sagittal slices, same thing, maxillary sinus clean, healthy, but we can see here, and the ENT surgeon highlighted it with this mark here. The implant is inside the nose, and we have some swelling of the mucosa, of nasal mucosa here, and we can see how the implant is inside the nose. So, due to this situation, we had to choose between one option that was remove the implant. Immediately, I think in remove the implant. But when I saw, I'm sorry about the image is not that good, but when I saw the CBCT scan, uh, there was if she lost this implant, if I just remove this implant here, you can see the implant here, the tip of the implant inside the nose here. This is the piriform ring, the edge of piriform opening here, and this is the apex of the implant, and this is the rest of the implant. And if I lost this implant here, of course I would compromise all the prosthesis, and I would have to place another implant, and she really doesn't have any bone to place another implant. So the only option it would be to go to a zygomatic. maybe a double zygomatic implant on the side and maybe a pterygoid implant on the back. But at first, the patient wasn't, very happy with this option. And I started to figure out how to manage this case without removing the implant. And this is a cross-sectional view of the implant. So we can see here the mucosa. We can see here we have the rupture of the nasal floor mucosa. We can see that we have swelling, and we have calcifications around the implant here. I don't know if this was any kind. At the time, I don't remember if I made some kind of nasal floor lift and tried to put a graft here, or if it was just a reaction to the inflammation. Sometimes the body forms these calcifications, dystrophic calcifications in response to chronic inflammation. So maybe this was the case, but the fact is that the implant was too much inside the nasal floor. So I had to make decision, and I explained it to the patient, and together I told her which were the options: remove the implant, or another option that I saw before in lectures of other colleagues and in the literature, that was try to make the apicectomy, to remove the apex of the implant and maintain the implant that is inside the bone. So I discussed this with the patient. Of course, we will remain with, the implant doesn't have that bony fixation, but it was really stable, and we opted to try this. So what I said to the patient was, we can try to maintain the implant, make the apicectomy, and so we will follow up it. And if you have any problem with the stability in the future, if you have any bone loss and the implant loses its stability, so we will have to go to the zygomas. So we talked about, and the patient agreed. And in January of this year, I made the apicectomy. So I made the infiltration of anesthetics intraorally, normal, but I complemented this anesthesia infiltrating through the nose. Okay, so I could direct visualize the apex of the implant inside the nose. So I infiltrated the mucosa of the floor of the nose with the anesthetics, and I made this incision here in the mucosa, and then towards the bone. It's very important to feel the bone, otherwise you must enter directly to the mucosa of the nose. This is not the ideal situation. So I felt the bone, and with the blade of the scalpel, we go feeling, touching the bone here, and exposing. This is the nasal floor here. This is the nasal mucosa here. And then I started to raise the nasal floor mucosa. And we can see here, as we had the perforation of the mucosa by the implant, that was already, the mucosa, the nasal floor was already perforated by the apex of the implant, so it was impossible to maintain the integrity of the mucosa. And as you can see here, we have this tear in the mucosa. Part of this was already there, but part of this, it was when I started to raise the membrane. And here you can see the perforation of the nasal floor mucosa, and you can see the apex of the implant here. And I just, cut the apex of the implant like we do with the tooth when we want to do a apicectomy in the natural tooth. Of course, we have to take care protecting the mucosa, and it's interesting. And I did it. You can't see here, but I placed some pieces, some small pieces of gaze of gauze, yeah, inside the nose here, because of course when we do this, a lot of powder, titanium metal powder is generated. So it's interesting to place something there to retain this pieces of metal. And it's important to really to use lots of saline solution, because otherwise you will generate too much heat, and this can be harmful to the bone, to the mucosa, and etc. So we always, cooling with saline. And here, before removing the tip, but already cut it, you can see the metal spread in the area here. So after we finish this work, we have to irrigate this very well and clean all this area, because sometimes these small pieces of metal can chronic inflammation in the area. So we cut the tip of the implant, and after you remove the tip of the implant, we should smooth the area with a diamond bore. So it's important to smooth all the edges of the implant, because when you cut the metal, we will have sharp edges that can in the future harm the mucosa here. So we smooth all the edges here. And we can see here, it's hard to take this picture, but I hope you understand. Here we have the perforation of the nasal floor mucosa. Here we have the tip of the implant already removed the part and then smoothed it here. So I tested it with my finger with the glove, so I could feel that we didn't have any sharp edges, and I was satisfied. And the nasal mucosa was sutured. It's easy to suture the nasal mucosa because normally it's thicker than, for example, the maxillary sinus mucosa. So we really are able to suture this mucosa. So this is something that happens a lot in orthodontic surgery, for example. When we down fracture the maxilla, sometimes we have some tears or lacerations in the nasal floor mucosa, and you just suture it with nylon or a resorbable other resorbable material, and this is easy to do. This mucosa in general, it's thick and supports very well the sutures. So we close that tear, that opening in the nasal floor with a sutures, and I placed it just to be sure that this would be really waterproof closed. I placed a collagen membrane over it, so, and also to isolate more the implant from the nasal mucosa. So I placed this double layer collagen membrane, and then I close the oral mucosa. So this is how I managed it. This is the tip. Of course, this is not all the implant that we removed, because some of the implant was just drilled, and this is part of the apex of the implant that we removed. So this patient will be back now in January. Of course, she came back. I removed the sutures. Unfortunately, I didn't document it, but she will be back now 1 year, January, 1 year after this last surgery that I did. And she will bring me a new CT scan. But until this moment, she has no complaints about the nose. It looks like everything completely healed, and I hope now we can really solve the problems of this patient, and everything goes well. And we are still waiting to see how will be the next step on this patient. For now, I just will follow up. Okay, and what is interesting and is that after all the this trouble that we had at all these years, the patient, is still happy with the treatment. This is very interesting. Is very confident with my work, and she really trusts me, and this is important in these situations where we have troubles, and we always have troubles. It's important to develop this trust between you and your patient. You have to be confident and show the patient that you solve the problem. This is very important. So this avoids of problems that sometimes you can have in these situations, as you know. So let me come back to the chat now.
We have a question, Mr.
Okay.
Khalid.
Okay, this just a minute, just to finish. So this was how I managed this case. I know that maybe there are other ways of managing these situations. This was the way I managed based on my experience, my knowledge, and of course, in these situations, I talked to other surgeons and asked for their opinion. So we have to be humble to that. Also, we never will know all the answers. And of course, you have to go to the literature, to the papers, and see if there's some evidence of this kind of treatment. That I can assure you that the literature is not very rich about managing these situations. But in the end, I think that everything gone well, and we are following up this case. And when this patient come back, I will follow up you of what happened. So I'm open to questions. Please feel free to talk about everything.
Could you read in the chat the last question, Dr. Khalid?
Okay. Let me see.
Thanks. Great learning case. Can I ask why? Did you see?
Did you change your practice to use layer of collagen to close fistula? Does it increase chance of post-op? No. I do not agree that this increases the chance of post-op infection. It's important to say that I just approach to close the fistula when there is no signs of symptoms of active infection. So the infection must be controlled. If you close a fistula with active infection, the thing is, if the patient has some problem of draining the infection through the nose, that it's natural way, if you close the fistula without assuring that this osteum pathway is patent. The drainage is okay through the osteum. So the suppression, the pus, will accumulate inside the sinus, and this will worsen the sinusitis and the signs of symptoms of the patient. So we just approach the fistula after a period of using antibiotics and anti-inflammatory drugs, and then we will do the closure of the fistula. So there is no infection, and so I don't know why adding a collagen membrane in an environment that it's clean, it's not under active infection. See, we have a sinusitis, but this sinusitis can be purulent, can be active, acute sinusitis, but we can have the chronic sinusitis. So we will do the procedure in a phase in which the sinusitis is chronic. It's not a acute, purulent, bacterial active sinusitis. So we have to be sure that we don't have any kind of infection at that moment, and then we are going to do this procedure. And in this situation, I don't see why a collagen membrane can lead to an infection. Not at all. And I'm using this approach for a time, and I think that more layers you add, more waterproof closure you will achieve, and so probably you will result in success of closing these fistulas. Okay. Another question here. I find sutures open up in the lower anteriors buccal side after implants. Any suggestion to these sutures do not open bone sutures? Yeah, I do it. This is one way these bone anchored sutures can stabilize more the sutures, and I don't do this always, but in certain situations, mainly when we remove a great amount of bone in the osteotomy, in the bone reduction. Yes, I used to do these bone anchored sutures, and yeah, it works very well. Neil, it's saying, thanks, Dr. Someone good to hear about complications management. When you cut the apical part, what did you use to cut? What at RPM, and how did you clean the area? And did it affect the stability of the implant? Did you smoothing the apical tip? Exactly. I did all of this in the sequence. So first, I used a carbide bore, like a 702 drill with 10,000 RPM. I really use a saline solution to cooling, because you will generate a lot of heat, so you have to avoid it. In this case, yes, I was afraid that I could lose this primary stability. It was something that I discussed with the patient, so I was really aware of this, and I followed up, and everything went really good. We didn't lose the primary stabilization or the secondary stabilization, the osseointegration of the implant. And to be honest, everything is under control now, but we're not sure that this will work on the long-term follow-up. But the important is to following up. The infectious disease were controlled, the complaints of the patient were controlled, and now we have to follow up the case. I think that something will be done in the future. Maybe we have to place another zygomatic implant, maybe one zygomatic and one pterygoid implant. But for now, I just will follow up the case. And yes, I smooth in the apical tip with a diamond bore. I think this is the best to do. Christian is asking, in a case of normal All-on-X with sinus perforation after months of placement, can I still save the implant? What would you be measuring? It depends. It depends, Christian. If the implant is too much inside the sinus, if you have a great part of the implant inside the sinus, I think it will be very difficult, because the key point is our ability to clean the surface of the implant. Because the problem is, the implant is exposed to the inside part of the sinus. It's really inside the sinus, or we have the mucosa over the implant, isolating the body of the implant from the sinus. This is what we have to know. If you have the mucosa over the implant, maybe you can just maintain the situation. But if the patient has complaints, and if you have food or liquid draining through the nose when the patient eat or drink, if you have pus inside the sinus, etc. Mostly, I'm sure that you will have to remove this implant, because if you have the implants that you have today, rough surface and threads, etc., you will not be able to clean this implant. So you have to remove this implant. If you are able to clean this implant, really clean this implant surface, you can remove them or you can maintain the implant. But it's not the case with these standard implants that you use in our X today. For example, all the zygomatic implants that I placed, and implants that were with threads all the way and with rough surface, all of the implants that were infected in this situation, I had to remove. But today, in the last cases I do, when I had sinuses, there's not many cases, fortunately. This is relatively rare to occur after zygomatic implant placement. But if I place the implant and this implant is all smooth, polished surface, so I maintain the implant because I'm able to really clean the surface of the implant. And then I have to isolate this implant from the sinus. So I normally will place a collagen membrane over the implant to isolate it from the sinus. So if I'm able to clean the surface of the implant, it's okay. But that's not the case with our standard All-on-X implant. So in this case, I have to remove the implant most of the times. Okay?
Okay, my friends. Now we are in limit of the time of the webinar. And I would like to say thank you for your time. Thank you, Sormani, so much for your knowledge. It was fantastic. And I would like to advise you, Sormani will be in Brisbane in June next year. I hope you can enjoy our course in Brisbane with Dr. Haggett, and probably in Melbourne too. I will talk to you in the next month about this proposed. Sormani, thank you so much. I would like to say very good Christmas to everybody and Happy New Year to everybody too. Thank you so much.
Okay, thank you very much. Nice holidays to everyone. And next month we're gonna be back with another interesting case. I separated the case. It was a case that I did with Rashi here. It's a very interesting case with transnasal and pterygoid implants that solving another case of complication on All-on-4. It was very interesting, and I hope to see you here to discuss this other case. Thank you very much.